Well, good morning, everybody, or good afternoon, wherever you are. Unfortunately, CONy this year takes place only virtually. We plan to have this important debate in London, but as the coronavirus prevented us from being there, we're going to do everything now virtually, and I hope that it will be satisfactory as well. So you've heard from my opponent about GWAS. Professor Hardy is one of the leaders in this field, and he tried to convince you that GWAS will help AD patients' care. The question is not whether GWAS is an important method or not, whether it's scientifically valid or not. The question is about application to Alzheimer's disease and to show that Alzheimer's disease can be treated better having the results of GWAS. And here I would hope that I can convince you that the answer is unfortunately not. So I have to again tell you that there are no conflicts of interest that I should declare, and let's go to the business. And the question that we have to ask first about GWAS, which is a very strong method, but is it reliable in terms of Alzheimer's disease? And are the results useful for MS therapy? And let's begin with what we mean by Alzheimer's disease. And you all would agree with me about the definition. The way that you will define Alzheimer's disease as well is that this is a clinical pathological entity of progressive dementia with specific neuropathological changes. And it is a complex problem, and I want to stress this, that Alzheimer's disease is unique in being defined by both clinical and pathological manifestations. There is no other disease in which the definition requires a combination of both. And this is because it's a complex problem, as I will illustrate in a second. So what does GWAS address? GWAS addresses only the clinical phenotype, not the biological substrate. So in this definition, it does not answer anything about Alzheimer's disease, but only about the clinical features, and even that is not really strong. So as I said, Alzheimer's disease is a complex problem. The problem is that we're taking in GWAS only the clinical phenotype, and we try, by looking at the clinical phenotype, identify the biological substrate. We know that the clinical phenotype on which we base our diagnosis is unreliable. About 30% are false positive. So if you see what happens, for example, here is a recent report from United States, where the best centers have provided at autopsy the brains of their patients with Alzheimer's disease for pathological evaluation, and it turns out that of these patients coming from the best centers in the United States, about 30% do not have Alzheimer's disease at all. The clinical phenotype is not really reliable in identifying the biological causes of the disease. 30% false positives. Now, what does it mean? These 30% have dementia, do not have Alzheimer's disease, so they have something else. Maybe it's frontotemporal dementia, which was not identified, maybe TDP-43, maybe this, maybe that, we don't know. But it's important because their dementing illness was wrongly assumed to be Alzheimer's disease, has its own genetics. And if so many of them have a different disorder, this will show up in GWAS as if these were indicators of Alzheimer's disease. So this is therefore what we see in GWAS, what Hardy showed you, is not necessarily specific to Alzheimer's disease. It may relate to coexistent dementia, to Lewy body disease, or to neurodegeneration per se. It is not a specific finding. So, also this 30% of those assigned as normal people, like perhaps Professor Hardy and myself, maybe we have Alzheimer's pathology in our brain, although you're all aware that we are not demented. If in such a study we were to be recruited, we would be recruited into a normal population. But so the normal population, the control population in GWAS, has a 30% noise coming from people who do have Alzheimer's pathology but do not have dementia. So 30% fall positive, 30% fall negative. Frequent amyloid deposition without significant cognitive impairment among the elderly, 30%. So the sensitivity of GWAS to identify these genes, the genes relevant to Alzheimer's disease, would be lower. So can we trust GWAS? No, not in Alzheimer's disease. It's a very important, very accurate, very demanding scientific study, but too many false positives, too many false negatives in the case of Alzheimer's disease. And so what we see here in this Manhattan plot, we see what you've already been shown by Prof. Hardy, a very high tower. The highest tower here in town is the ApoE tower, and then there are additional ones that we'll talk about. So let's start talking about ApoE first. So what did GWAS teach us? That ApoE is a risk factor? It's not the GWAS told us that. We know about it for 30 years. We are aware of this being a risk factor for a long period of time, and it has still not helped us to find a cure for Alzheimer's disease. So even identifying a genetic risk factor does not translate soon to a cure. So will GWAS help us AD patients care? If we have not solved the ApoE issue, which we'll talk about tomorrow, how can we think that it will help us to find other things? What else did GWAS teach us? There are other risk factors which are less important, much less important than ApoE according to the Manhattan plot. They are not so high, the towers there, but they're there. And when we try to find out what they are, so what we see is that some of them are inflammatory markers or immune-mediated disease or cholesterol and lipid metabolism. This account for most of these above threshold small towers. So again, this is something that we see in GWAS, but again, this is not new. We know about inflammation being involved in the Alzheimer's brain for decades. And we know that cholesterol is important because we try to reduce the dyslipidemia in patients with cognitive impairment in any case. We didn't need GWAS to tell us that. What did GWAS not show? For example, it did not show us anything about amyloid and tau. Amyloid and tau. Amyloid, you remember, it's not here. So you remember John Hardy, the famous John Hardy, 30 years ago, told us that amyloid is the most important factor in Alzheimer's disease. In fact, he said that Alzheimer's disease is an amyloidosis of the brain. And yet it does not appear in the GWAS. A lot of the studies that have been done trying to find therapeutic interventions in Alzheimer's disease were directed against amyloid, and we'll talk about it again much more tomorrow. But again, this was not based on GWAS. GWAS would not have told us about that at all. What else? GWAS does not take into account additional pathology, particularly vascular. So patients who are included in the study as having Alzheimer's disease may also have vascular pathology. In fact, this is very common. Have we seen vascular risk factor arising in Manhattan? No, none. So what does it mean? What did GWAS teach us as well? And that the question here is a more basic one. So what it shows us is that there is a statistical difference between the so-called Alzheimer patients and the so-called normal. The statistical significance is not the same as clinical significance. And I think that we don't know, and we've not been told, what is the effect size of each of these risk factors. For ApoE, we know that ApoE4 is an important risk factor because we know that it affects about half of the patients with Alzheimer's disease. Half of the patients with Alzheimer's disease carry ApoE4. We wouldn't be able to know this just from the GWAS. GWAS does not tell us what is the effect size of each of these risk factors. So in conclusion, GWAS looked at the clinical phenotype, not the biology, but it attempts to tell us something about the underlying biological processes, which is not feasible. It disregards the inaccuracy of the clinical diagnosis, both of having Alzheimer's disease and of being normal. It disregards copathology. It did not discover anything very new. It does not tell us the effect size of each of these things, so therefore it is unlikely to affect the management of our patients anytime soon. So again, will GWAS help us find anything that can help AD patients' care? Not anytime soon, and I hope that in the voting you will see that you will be with me and you will vote no for the question, will GWAS help AD patients' care? I thank you very much for your attention. I'm looking for the vote, and there's more time for debate, questions, which both John and I shall be very happy to try to answer. Thank you very much.